Welcome, everyone. I'm Rachel Shelton. This is part of our monthly CTSA Columbia seminar series on implementation science, and we're really thrilled to have you join us. I know that today we have people across Columbia, but also some of the leadership and team members from our U54 consortium through NCI as well. So welcome. So today we have a very exciting topic. We have Dr. Delivette Castor who is joining us to talk about the Payback framework, which is a framework that we're using as part of our center. And she's going to be talking about its application to assess the impact of implementation science. A little bit about Dr. Castor. So she is an assistant professor in both epidemiology and medicine in the Division of Infectious Diseases. She's an epidemiologist who really studies the scaling and implementation and uptake of public health innovations at scale. And she's done this really across a range of settings, including low and middle income countries, but also in the US context among marginalized populations. She has a very long history of work prior to joining CUIMC in 2019. So prior to that, she led implementation research activities within PEPFAR at two US government agencies. She also she was senior epidemiologist in the Office of the Global AIDS Coordinator and has led a lot of implementation science work as the acting chief of implementation science branch at the HIV/AIDS office. So really a wealth and history of experience. And I've been really lucky to work with her as MPIs of the U54 Center across Columbia. So please join me in welcoming Delivette. Thank you.
Thank you, Rachel, for a lovely welcome. And I also feel really lucky to have worked with you. Um, just a little bit of disclaimer. Part of one of my impetus is to come back from government to academic settings was because I realized that this field, as we were sort of doing some things in practice, was also codifying a lot and really wanted to learn, more about the theory and the frameworks than how I had come into it. So as Rachel mentioned, I'm trained as an epidemiologist, and I came into implementation science by way of program problems. And so I still ask for forgiveness if I butcher some of the vernacular, but I've been really lucky to have found camaraderie and collegiality in many of the people within the university as we work and learn together. One of which is Rachel, which is her South African name. So that's probably the only global health thing we'll be able to talk about this week. So I will do this a little bit before jumping into the framework, and I'll start with just some program setting. I'll talk about the global HIV context because that's how I came to think about this framework and to utilize it. And the example I will provide of its application mostly is drawn from that from that experience. So I'll set the stage and do quite some time setting the stage, in particular because of the sentiments of this week. So starting, as many of you will know who do HIV research, the global epidemic of HIV still continues, the pandemic. There are roughly 40 million people who are still living with HIV in the world. And although we've seen declining rates in many places, about 10 countries in the world account for nearly 50% of new HIV infections still. The large majority of them remain in sub-Saharan Africa, but we'll see some other country settings like Russia and Brazil also contributing, and India contributing a significant proportion. And while we see in general a global decline in HIV and AIDS, in some settings, particularly some of those that are contributing to new infections, we have been seeing upticks. So it is by no means the time to roll back efforts. And some of the decline, is often debated. How much of it is sort of the natural cadence of infectious diseases distribution, but also because we've been fortunate to have a lot of advancement in biomedical HIV prevention and what we call comprehensive or combination HIV prevention. Since 2007, we've had evidence showing that the intervention of voluntary medical male circumcision can reduce HIV infection by nearly 60%. We've seen treatment as prevention, which also has, very striking rates of reduction of HIV, also upwards of 90%. Similarly, for daily oral PrEP and in another modality, which is an event-based use of or intermittent use of oral PrEP, we can also see considerable reductions. And then 3 years ago, we had approval of the monthly Depiferin vaginal ring, which is used primarily in sub-Saharan Africa. That's also being rolled out. And then about 2 years ago, we had approval of the bi-monthly long-acting cabotegravir. And as of last year, we had the first product that demonstrated 100% efficaciousness. And it is a 6-monthly product, so a person would just get 2 injections in a year for preventing HIV, and that's the 6-monthly lenacapavir, which is also being planned and rolled out mostly in sub-Saharan Africa, but also certainly here. And in the context of these prevention and success in treatment, we've also had a lot of wraparound services. Maybe one of the most prominent ones that's been discussed is the DREAMS program, which really sought to address HIV vulnerability in adolescent girls and young women who bear a disproportionate burden of HIV. And that stands for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe. And that program started around 2015 and continues today. And so while we've seen the decline attributed first to, in large, to the goals within the achievement of the treatment continuum of testing 95% of people, which is the goal for 2030, treating 95% of those who test positive and achieving viral suppression in 95% of those. And that has dovetailed with a number of prevention targets that include giving combination prevention to 95% of people who are eligible or in need, reaching 10 million people with access to HIV PrEP, also covering voluntary medical male circumcision by 90%, and also safe injection practices and substance use therapies such as opioid agonist interventions. And all of this now is very clearly bedded in an enabling environment that addresses policy barriers to HIV prevention, as well as discrimination and stigma, and financing being one of the chief considerations. So some of the analyses addressing the gaps that help us, that we're trying to address to get to the end of HIV, we put in 4 buckets. Still continuing our political and leadership gaps. We can talk about some of that we're experiencing right now, but globally, there are many policy barriers, particularly for key populations who may not be able to access services due to policies and laws around criminalization or gender issues and so forth. Certainly core to what we do is the lack of systematic implementation and scaling, with the inclusion of integration, and then financing, particularly around prevention programs. And as Rachel mentioned, I came into the work of implementation science after spending about a decade in the President's Emergency Plan for AIDS Relief, the PEPFAR program, which was the largest single investment made by the U.S. government for a single disease. And here, I think, still reflects the legacy of that investment. This is a slide that was taken from an advocacy group sort of tracking HIV resources globally and sort of paying attention on this really giant in the field of HIV support globally. And what it shows are the different funding agencies, and you can see that through bilateral support from the PEPFAR program, nearly 47% of HIV dollars that go out in the world comes through that mechanism. And then the next largest thing is through the multilateral organization, the Global Fund, which the US government also contributes a significant component. And after that, we see decreasing percentages from other countries that contribute to the HIV response. So when we say PEPFAR, this is sort of what the family of PEPFAR government agencies that are implicated. So typically what happens, the funding and the demarcation comes through the Secretary of State. Many of us will know of, have heard of the Global AIDS Coordinator, currently who's John and Kengasan, previously Deborah Burks, and there are a number of other people who've been in this role, who then oversee the program and the activities that cut across a number of U.S. agencies. The Department of Health and Human Services through CDC and NIH, U.S. Agency for International Development, which is the primary arm for delivering a lot of development services and assistance to other countries, Department of Defense, the Peace Corps, Department of Commerce, which many people are surprised to learn, and Department of Labor. So those are the agencies that then get assistance funds to support this work. And currently PEPFAR is working in more than 50 countries, and the current strategy really seeks to address health equity for as long as we can speak about this, a sustained response, public health system strengthening, and really having some transformation in partnerships with countries that they work in, and that all of this is based on science, which is what I will talk about a bit, and the foundations with community leadership, bringing innovation to practice, and learning with data. And so I think a lot of the terms in what PEPFAR intends to do sort of speaks to the practice of implementation science. And this is just a quick slide that talks about sort of the success in 20 years, with $100 billion estimated as the investment since the inception of PEPFAR in 2003. So here I'll shift and talk about what has been the role of research and evaluation in PEPFAR. And in research, we embed implementation science. So this is just a quick figure that sort of gives the trajectory of what we called research in PEPFAR. So as many of you may know, and others who aren't aware, when PEPFAR was initially created in 2003, this was really an emergency response phase. It was really to address the observation of the dire conditions under which people were dying in many countries outside of high-income countries where they didn't have access to antiretroviral therapy. Research was not really part of the practice, and it wasn't what Congress had mandated to do. However, people saw problems, and so part of addressing the problem meant that we needed to investigate it. So lots of terminologies were used to describe the research that was done in the context of these program practices. One of the more common ones was public health evaluation, which sort of what we were calling it in the early years, the first 4 years. And then around 2008, there was a bigger shift to do research, and USAID classically had done a lot of research around operations research, impact evaluation, process evaluations, which are related to but not the business of implementation science as we classically think about it. But it was on that framework that implementation science started to come into play in the second phase of PEPFAR. And so this is where I spent a lot of my time. And this was really around seeing that all of these new innovations, these new interventions were being developed, and understanding how do we introduce and expand them across all of PEPFAR supporting countries. And then that went into the now third and fourth phase of PEPFAR, which really sits to address transparency with the use of data, accountability, and continues to assess impact of the program. And this has been done using a number of data sources, including monitoring and evaluation, costing data, investments in survey and surveillance data, one of which Columbia also has led through the FIAS, Public Health Impact Assessments, and a number of other surveillance measures to understand its role. And so the service of research in this context is a big tension because all the dollars come in and then they're disseminated and decided through meetings and processes that are called either country operating plans for the country level decisions of funding, or headquarters operating plans for what happens within Washington, D.C. across all of these agencies. So it is a real fight for dollars. So when we get investments to do implementation science, it was a very clear understanding that the value proposition meant that we were not going to procure antiretrovirals to treat another person. We were not going to procure antiretrovirals to provide prevention. We were not going to do another circumcision. And that was the vein in which programs functioned with research. And that's how I came to understand it. So forgive me, but I always use these slides. And for those who've been to any of my talks before, you will know it. But before I learned about the frameworks, the way I learned and thought about implementation science as an epidemiologist in programs was that we were trying to address this virus. And the classical work that we did in biomedical sciences try to understand, what is the relationship between the virus, the person, their partnerships, their home life, their community. And this is often what we think about when we think about biomedical research. And what does it take to render a person either prevented or if they're infected, that they continue to live well? And then we got into this program space of having all of these new interventions. And then the question was, well, how do we get this product to this person in the way and quality, in a dignified way that they can use it when and if they choose to do it? And I started to learn about a lot of things that I knew nothing about. Supply chain systems in the health information. Where does the product get, where is the product starting? How does it get into the country? What are the systems in which the product is housed and disseminated and centralized, and the whole ecosystem of how that is buffered to ensure that product is intact and safe? And then there's the issues around the health information system. What is recorded, what is not recorded, is it interoperable, is it transferable, and can we triangulate the information to understand how all of this is happening for that person and for the device? And then comes the health system itself. Is this something that has to be facility based, or can it go out into the community? And what are the points of service delivery that also makes and improves access and acceptability? And a lot of that is done through a lot of what we call meeting making, the coordination and the stakeholder and partner engagement that happens. And we spend, and can be, for many of us who are based in science, an inordinate amount of time, and not often our ethos, but really fundamental to ensure that these things happen. So this is how I thought of it, and I have since learned that these are what we call strategies. So it's really about how we develop and understand the why, the bundle of things that come together to get this thing, the intervention, delivered as we should. And that is often predicated on the fact that there's guidance. In most countries outside of the US, there needs to be a national guidance and often a subnational guidance that allows people to really put wheels in motion. And often that is predicated on the fact that these national policies are interacting with multilateral organizations that also develop policies. Because of the way funding works and how health investment operate in many countries, there may be influences from external and private stakeholders and funders who are also involved, philanthropic organizations and so forth. And much of that is predicated by global policy, most notably the World Health Organization. And so often the policy will start there and then, be adopted as we go from country and then implemented through operational plans and practices. So when I came to think about what are the bottlenecks, these are the fundamental questions we asked ourselves in the program. Is the bottleneck here, that we are not able to get product to the person, the intervention, the thing? Is the problem here that we need to figure out whatever we're doing, that we bring the science back at this level or this level or this level so that it trickles down to facilitate and enable the environment for change? And so some of those data sources were that we would do formative work. Often it involved mathematical modeling or policy analyses. Many of these were things that I had not done in my prior research that was biomedical. And in this space also involved the work that is called implementation science, operations research, and many economic analyses, and the application and use of monitoring and evaluation data, quality improvement, and then some of the other classical work that we do. So I'll just give a couple examples of how implementation science played out, or what might look like implementation science but didn't have the title. So for instance, I came in just as the voluntary medical male circumcision clinical trials were being concluded that demonstrated that almost consistently 3 trials were done in a short period and showed across a variety of settings that they observed in clinical trial setting a 60% reduction in HIV acquisition in men. WHO had convened and prioritized some country settings. And then we came into the space to understanding, well, first, from these settings, what do we understand? So we started first with cost and impact modeling that really started to help countries develop and adopt the WHO guidance as part of their national plans, helping to understand the populations. Then we get to the other aspects of it, the implementation piece of it. So what did we understand about implementation that was needed? So first was the packaging of the intervention. Was it, this is a surgical procedure, so I think a lot of people even questioned at the time whether we could scale a surgical procedure for public health impact. And whether there were other ways to develop that made it more nimble and could be distributed for adaptation and adoption on a wider scale. Certainly, we encountered many issues around costing and commodities and the supply chain, and so there were lots of questions on that. Understanding how to engage and communicate, and what are some of the strategies to improve communication and access. Workforce diversification, including task shifting and task sharing, assessing capacity at sites and improving it, and a lot of work on system strengthening and data utilization for decision making. And what we saw through those efforts is that, for instance, in one setting in Nyanza province in Kenya, we saw that from the onset of the guidance for WHO in 2008, by 2011, just 4 years later, they had achieved 60% coverage of services. And on the right-hand side, we show here WHO's and UNAIDS tracking of male circumcision, and you can see what the coverage looked like within the first 10 years of the intervention. Those lessons we then applied to the introduction of pre-exposure prophylaxis. And this is one example of a publication by Pragna Patel, which recently came out showing sort of what the recent scale up of PrEP in dream-specific services that were addressing women and girls look like. And then another large investment. So as we invested more in research to help really push programs forward, there was a big dialogue around what was called comprehensive or combination HIV prevention. And these were really sizable investments in research, in implementation science and impact evaluation to assess whether we can really make a difference at the population level. Most notably, the ones invested by PEPFAR was the POPARD study, the SEARCH trial, and then the Botswana combination prevention study. I won't talk about the dollar amount publicly, but it did create a lot of fodder, much discussion. And the question was, for the amount of investment that then, as I mentioned, would not have treated a person, provided prevention, circumcised a human, what is the impact of PEPFAR's research and evaluation investment? And then the question was, how do we define impact, and how do we then ascertain whether we can have attribution or contribution to the research investment? And this really fits right into the way we think about this cascade or the odyssey that we talk about that implementation science is really trying to address. So I showed one example of where we were able to make achievement within the male circumcision service delivery that sort of usurps this idea that it has to be a 17-year journey. And I'm really condensing a lot of discussion and work into a very short period. And really trying to understand again, with the archetype of these different models and frameworks that are utilized in implementation science, how can we also use them to better understand what the impact is? So I'll talk about an example of one that is an evaluation framework, and that is what the Payback model is. So in the midst of these really large investments in implementation science came the debate, which is one, as the programs are doing, and some people will say, well, Kenya or another country would have gotten to 60% with or without your research, my friend. And so, how dare you take credit for that? And this is really the debate because, as we work in the context of trying to ensure that our methods are rigorous, that we are developing data and information and evidence that allows programs to actually propel the innovation to scale. And sometimes that tension is not met, where by the time we've developed the protocol, the program has moved on and the research is actually playing catch up. So are we, as an epidemiologist, we often say we just want to find the top of the curve and ride it into glory. And so this is the question with implementation science, which is, are we telling a story that was told already in really nice words, or is the science really driving the change that we profess to want to do with this science that I used to call a pragmatic science before learning much of the terminology. And so this is where the dialogue comes in. So we sought to try to answer that question in the context of the PEPFAR program. And because, as I mentioned, of all of the challenges with the nomenclature, it's actually really hard to trace like what is what. What was an implementation science study? Does it have all of the types? And can we get enough of it before we all expire to tell this story? So we decided to kind of rein it in a bit. And then in this case, we used a number of funding announcements had gone out, really responding to the call to do implementation science in the context of programs and to do it well. So during the second phase, we had put out a program announcement and funded 10 awards. And they were all addressing what was deemed scientific priorities by the PEPFAR Scientific Advisory Board. So it was about care and treatment, bridging care and treatment to prevention, prevention itself, and cross-cutting issues about population ethics and ownership. And so we decided after these studies had been done to then try to understand what their impact was. And this is where the payback framework really came into play. So the playback framework, or the HERG model, which is the Health Economics Research Group, is a UK-based group that had developed this, and it was done specifically because they were, like us, funding agencies that were trying to respond to what was the impact of the work that they had done. And so this model has 5 categories or stages. They're not, in the visual of the model, you will see they have stages. They never actually tie these categories precisely to the stages because there's some fluidity and some complexity to it. But essentially, it sort of goes along the idea that, first we would produce knowledge production. So that would be a key input. There are definitions around the benefit to future research, and I'll talk a little bit more about what that means. And then there's also benefit to policy, benefit to health and the health sector, and then what they call broader economic benefits. And then there are really conceptually 2 interfaces that they propose when the implementation scientist researcher is interacting with the user partner in this. We propose that actually part of what allows implementation science to not only fulfill the scientific rigor, but to make the promise is that that interaction needs to be much more intensive at that interface between the stakeholder partner and the researcher. So again, the rationale for using it is, one, it incorporated thinking around collaborative research agenda setting between the researcher and potential users. We also like that it was forward tracking and iterative, that it really highlighted the stakeholder interface where researcher and the end user come into contact, and that it covered a range of domains beyond scientific publication to really understand the contribution. So the portfolio that we used to test this example, here you can see this is the award amount and the period in which these studies were done. And so we thought it was tight because all the awards were made around the same time. So all parties had an equal opportunity to have had an impact, so to speak. This is by no means a judgment to anyone. Again, this was done entirely retrospectively. And so there's certainly, we try to be mindful of the skittishness that one might feel, feeling as if they were evaluated post hoc on standards that were not set up front. And that's actually one of the reasons why we're using it up front and the argument we make. So we used a checklist that was adapted, that was developed by another co-author that included both semi-structured assessments. We piloted it with another portfolio within USAID's implementation science program to see how it would work, and then administered it with the principal investigators or respective members of their team during this period of time. And so within the categories that I mentioned, the first was knowledge production. So these are the things that we live in every day in academic settings. They're conference presentations, peer-reviewed publications, write-ups that go into the degree literature, and other products that one might produce. Benefits to future research includes individual level capacity building, institutional capacity building, so lots of the things we do around trainings and workshops. And then, even qualifications, how members of the team are promoted or graduated into different roles and positions, and then advancement, and certainly the other part being contribution to future research or how the work is cited. So did this work then produce other grant opportunities that pays forward? The third category, benefits to policy, looks at how this was adopted by decision makers, whether it was cited or acknowledged anywhere in documents, whether it is expected to influence policy because they're in the midst of the dialogue. So we understand that the time frame is short and the arc for this kind of influence is longer. And this is one of the biases of doing this assessment then, as opposed to now, for instance. And then so also whether it led to any development of policy changes, either at the institutional or at some geographical level that's expected. And then changes to the health and health system is around quality improvement of services, increased effectiveness, whether there was, how is one measuring gains in equity? What does that mean and how is it operationalized for the entities? What are qualitative improvements or quantitative improvements that they could assess directly within the program setting? And then the broader economic bit was, again, changes to the health workforce, reduction in cost, which is one of the biggest barriers in most development settings for why things aren't implemented, and then or expectations about cost reduction when the work is disseminated. We then conducted a desk review. So in addition to what we got from the principal investigators, we wanted to ascertain whether we can assess some of this objectively as well. And so this desk review involved reviewing study proposal, reports that came in annually, management plans, tools. We reached back to some partners to see what job aids continued to be used. We went into various PEPFAR repositories on the web, and then publicly available documents to see whether the work had been cited in any of the national plans, guidances, and so forth. And so here we have a quick summary of the partners and countries that you will see on the left-hand side. These are the leading implementing partners and the countries in which these studies were conducted. And then this is a summary of the achievement for each of the categories. All the questions that we asked, all 10, we were able to identify knowledge production in all 10 of the programs that were funded. Benefits to future research, also documented in all 10. There was some indication of benefits to policy in all 9, and I'll talk about a bit of those variations. And then benefits to the health sector in terms of services on site, who you're interacting with. We saw that was only demonstrated in about half of the programs that we examined. And then broader economic benefits was quite meager at 2. Again, part of that may be timing, and it certainly was a really interesting dialogue with the PIs and the teams as we were sort of talking through this, because many people felt like these were not things they were thinking about at the outset of the work, and that it would have been helpful to kind of have that intentionality, particularly, from the perspective of attribution, which I'll talk about a little bit more. So as I mentioned, for knowledge production, all of the awards demonstrated some evidence of that. Most of it was that they had presented at least a scientific conference. All but one had produced some form of gray literature, which we often think is more accessible to the lay public, and that was part of the impetus for thinking about it. Only 5 had developed products that were used by stakeholders at the site level, like standard operating plans, job aids, training guides, reminders, or any kind of service support product. Often we think these are not scientific documents, and so they are deprioritized. And this is one of the things that, really does help programs to move forward, and we thought was quite notable and sparked a lot of discussion actually among the researchers. In terms of research to benefits, again, all demonstrated research benefits, particularly with trainings and seminars. About 5 of them were doing institution to institution capacity building activities, which is much more robust. And there was an expectation that there would be either gaining formal qualifications, so people who had moved from being a recruiter to a next position up, as well as people gaining degrees. I didn't have that there, but we also tracked like how many people had no degrees, got a bachelor's degree, had a bachelor's degree, got a master's degree, had a master's degree, went on to do their PhD training. What I will note is that I didn't include it here, but we saw quite a disparity between the professional advancements for US investigators versus what happened in country. And then 7 of the projects indicated that as a result of this funding opportunity, overall, they identified about $19 million of additional funding that was gained as a result. So yay. So then we get to the policy benefits. And this is also a little bit more complicated for people to figure out and track. Sometimes, again, attribution is really difficult. And so 6 studies reported that their findings had influenced some health-related policy and decision-making, often at the more local level, but we did have some instances where that shaped and showed up in global policy and in national policy. Health sector benefits, we'll see that the average payback score was about 30%. 3 studies expected that their studies would influence national changes, and we can talk about, and I didn't want to disclose any studies' identities, but really, studies that, one of the studies was addressing prevention of mother-to-child transmission, and that actually was really instrumental in the change in that country. And 2 studies reported benefits that had already happened or results that they were expecting in the process. And so again, this is the timeline of when do we do this kind of evaluation. The broader economic benefits, that was the lowest one, and no studies reported any economic benefits or cost reduction in service delivery as a result of the work that they had done. One noted that they were expecting that there would be some economic benefits, and again, attribute that to the timeline issue. And so in summary, we concluded that the total payback was about 43%, indicating that programs reported positively on less than half of the measures that we had across the 5 impact categories. And not surprising that much of that came from knowledge production, and came from benefits to future research, which is what many of us are in the business of doing. But I think really helpful to think about the other end of it, and the other end of the 3 factors that are impact, or even thinking about whether those 3 are sufficient and there may be other ones to explore. But there are some challenges with the model. There are lots of complexities and nuances in how, evidence gets borne out and is accepted and adopted. That sometimes is not within the capacity of the researcher. So so there's a recognition of that and understanding how to do that. And again, the tension between attribution and contribution, even if your work isn't cited, but was the thing that started the thing that got recognized, so it contributed to the change, but may not have been identified. And I think where we left it was that one, certainly, we advocated for funding agencies to also, just like we know in the business of the research that we do, that if we don't publish, it's really difficult to come back with a new grant with no publication cited on the last one. And so, in the context of implementation science, what should those metrics be beyond publications that says that we did good work, and that it made a difference. And when you come back to the funder and you come back to the people, that we have a body of evidence that says this is what the change making looked like. And so the other advocation was actually that researchers should start to monitor their impact with intention, even if the funders do not, and maybe then we can develop and think about more appropriate metrics, categories, and how do we operationalize them and have some consistency with them. And so that's where we are with Rachel and friends. And so we're working on this as we expand and work with our colleagues in South Africa as one of the U54 mechanisms, where we work to introduce HPV-based screening and treatment into primary care settings in the Kailisha community. And we're using the Payback as one of several frameworks that we're using to really be able to assess knowledge and capacity building, research capacity, and really, the work that goes into integrating services. And so I'll end there. And my last bit is that, we planned this. When did I say yes to this, Rachel? Quite some time
Fall.
ago.
Yeah, a while ago.
And here we are, on the last day of a very tumultuous week of all of these things about how, a different term thinking around payback, but certainly difficult times to be operating in this space with the U.S. government deciding to withdraw support from the World Health Organization, which I mentioned is a critical part for how countries adopt policy and programs. And then the other one is that there's been a 90-day pause on all foreign assistance as of right now, from the perspective that they're not aligned with Americans' interests and values. And so, so all of these are the complexities in which we do development research. And I was saying, I hope I don't give anyone PTSD, but it's not a P because we're in it, TSD, with putting this up. But I thought it was a reasonable point to stop and take questions and discussion. And I'm so happy for so many of the names that I see on here to hear your point of view and to learn more from you. Thank you.